Hey guys, welcome to this quick tutorial on the Cheetah non-invasive cardiac output monitor. Hopefully within a few minutes after watching this video, you guys will get the hang of it and be able to use the Cheetah on the go. None of the members in the video or listed at the end have any conflicts of interest. There's no relationship with Cheetah whatsoever. So what is NICOM? It's a non-invasive cardiac output monitor, and it uses something called bioreactance. We really don't need to know it. Basically, it's voodoo medicine for all we care, voodoo science. You just know that it has to do with a voltage being shot through the chest wall into the fluid content, specifically your blood cells, and then there's a phase shift depending on the volume status, and that tells the machine the stroke volume beat to beat. There are some main limitations. If you have any aortic valve disease, specifically severe aortic insufficiency or something like a aortic dissection, for instance, or a thoracic aortic aneurysm, that's going to affect the ability of the NICOM to read accurately. And as well, if you have any external pacemakers, that may affect your measurements. The key thing is that the lead placement has to be on clean, dry skin, and that it needs to be in the right orientation. So what do you need so far? You need the machine, which is this right here. You need a BP cuff, which is included in the box, and you need a set of leads. Each set of leads comes with 4 electrodes, and they are all oriented right, left, and up and down. Each set of electrodes or leads actually will cost you about $150 to $200, and they're sealed in this black package right here. So unless you have a patient, do not break the seal. So how do you set up the patient? First, you want them 45 degrees supine in the recumbent position like this, and you want to have access to the chest and abdomen, so you want to expose that. And if you need to, in our hairy individuals, you need to shave a little bit. And the package of the electrodes actually comes with these little skin sanders that can help to smoothen out skin as well. And what you're going to do is you're going to place the leads essentially in above the clavicle right here on both sides, and then anywhere inferior here. And you'll notice that each set of leads actually has an orientation. So this is the red, and it shows you that it's below on the left lower side of the body, and this is the left upper part, the right upper part of the body, and the right lower part. And you'll notice that there are also little tabs right here. Point the tabs inferiorly or to the feet. So how do you set up the machine? So once you put the leads on, one pair of leads will have red heads like this, and the other ones will have clear or black. So the red will go into this red receiver, and then this one will go into the black receiver, and they'll combine to have a cable which you plug into the machine right here. The blood pressure cuff plugs into here, and once you have everything plugged in, you press this green button right here. Hold it until it beeps. You'll get this right here, this main menu. You'll want to hit new patient, and once you hit that, you'll have to input some data, including the study ID, age, as well as weight and height of the patient. And then it'll go into calibration mode. It'll say automatic calibration in process, please wait. And during this 3-minute interval, you really want to have the patient move as little as possible. Once your calibration is done, you get to see some really cool measurements. Basically, you have your cardiac output right here, your heart rate, blood pressure, your vascular resistance right here, and stroke volume index and the stroke volume variation right here. You can actually toggle in between screens by pressing the up and down buttons right here. And you can see that there are actually different displays that you can use, including a trend display, which is pretty cool. It'll plot some of your key data over time. In terms of our study protocol, one of the things that we're going to do is to do a passive leg raise. And remember that a passive leg raise is an auto bolus about 300 to 500 cc's from your lower extremities to your thorax, it's completely reversible. And if you see an increase in the cardiac output or stroke volume of anywhere from 10 to 15%, depends on who you read or what you read, they're fluid responsive. And if it's less than that, then they're not fluid responsive. And basically, to do this procedure, you really need 2 people on board. One to help you with patient positioning, and the other one to actually set up the machine. Now, you could have the sonographer help with the positioning or do the positioning and then scan, and then you can have the other person set up the machine. So how do you do a passive leg raise? This is really important. Remember that with your first position, your semi-recumbent position, you have the patient's bed elevated about 45 degrees. What you're going to do is you're going to actually put them in Trendelenburg about 45 degrees from the ground, and then you'll lift up the head of the bed so that it's flat with the ground or parallel with the ground. And this way you actually have the legs actually in 45 degrees in relation to the patient's trunk or body. And so you want to be able to put the patient in the passive leg raise position immediately before you actually start the procedure on the machine. And in order to start the procedure on the machine, you go into your menu, go to protocols right here, and select the actual passive leg raise test right here. And when you do that, it'll ask you if you want to use the same data that you just collected as the baseline. You want to select yes. And before you select yes, make sure that the patient is in the passive leg raise position, and then hit yes. And this is the data that you get. You get a Frank-Starling curve. You also get the stroke volume variation or percentage change, so 13.8%. Remember, 10 to 15% is your goal. And you also get some cool stuff like your cardiac index, heart rate, etc. Let's end with basically some common questions. So the first is, what if you're afraid the leads are going to fall off? What if it's someone who's kind of sweaty, etc., or you've tried to shave them and they're still a little bit coarse. What can you do?
I put a tegaderm on as soon as you get a good tracing. Go ahead and put a tegaderm on. Remember when I said don't touch them, don't move for 3 minutes? Once that 3 minutes is up, put a tegaderm on when you know it's working just fine. You need 4 big tegaderms to go over every lead, and that'll help hold the leads in place.
Great, thanks Dr. Stein. Next question is, can I guess the height or weight? So ideally you should have a measured height or weight, but patients are going to be septic and they're maybe unresponsive. You may not have the time, so you can just visually estimate the height or weight. Or, if the patient has family members nearby, you can ask them about their approximate height or weight. What about the ideal body weight? Dr. Weingrove?
When we're using patients' body weight, are we going to be using patients' actual body weight or ideal body weight?
Actual body weight, because you're going to calculate an index, so it's going to give you a cardiac, actually it's the other screen, cardiac output, cardiac index, and it'll give you a stroke volume and a stroke volume index. And if you forget what the normals are, they're on this cheat sheet.
So like Dr. Stein said, you're actually using the actual body weight, not the ideal body weight. And there are some references in these cheat sheets right here, or these guides provided by the Cheetah NICOM company, and they're tucked into a plastic clear envelope underneath this machine right here. Okay, let's wrap up with some key points. First, we need to assess the clinician's pretest probability of whether patients are fluid responsive. This is important because we're studying whether ultrasound can actually predict fluid responsiveness, and as well as whether it can improve the clinician's ability to predict fluid responsiveness. So we need to get the clinician's assessment prior to the NICOM as well as the ultrasound. And lead placement on clean, dry skin as well as the calibration process are key. So remember that you need 3 minutes of the patient holding still for the calibration. We didn't really talk much about this, but the stroke volume variation, which is reported by the NICOM, is how we're actually going to see if they're fluid responsive based on respiratory variability. For measures that rely on that passive leg raise protocol, we're going to actually look at that delta stroke volume and delta cardiac output or index. Remember, if you're manning the NICOM, don't show your results to the sonographer because you don't want to bias the sonographer. And last, these are the members of the study team. If you have any questions, don't hesitate to ask any of us. Thanks again for watching our video.